Good afternoon, everyone. This is Dr. Gary. I'm a board certified reproductive endocrinologist and infertility specialist. I am the chief medical officer of Fertility Cloud, telemedicine fertility practice. And today we have the distinct honor of having Dr. Erin Wolff, CMO of Pellex, and also a board certified reproductive endocrinologist, join us for a fireside chat on polycystic ovarian syndrome. I have the distinct pleasure of welcoming my good friend and longtime colleague. Well, I hope she's my friend, but longtime colleague, Dr. Erin Wolff from Pellex. And one of the things that we'd like to talk about today is PCOS. So I've never done people justice when I introduce them because I always forget some very important credential. So Dr. Wolff, if you don't mind, do you mind introducing yourself?
No, not at all. So I'm Dr. Erin Wolff. I'm an OB-GYN and reproductive endocrinology and infertility specialist like Dr. Gary. We both trained at the NIH, and now similarly, we're both passionate about doing telehealth to help patients get into the fertility clinic earlier and not wait too long.
Absolutely, absolutely. So I'd like to add that Dr. Erin Wolff actually trained me. So when we provide care, it's under the guidance and the astute training of Dr. Wolff. So first, I'd like to extend my gratitude to Dr. Wolff for being a very compassionate senior fellow and not overly malignant senior fellow. So Dr. Wolff, again, thank you so much for joining us on our chat. One of the things that we've definitely run into is I don't want to use the word misdiagnosis, but the enigma of PCOS when we see patients. Obviously, we're trained in, taking care of patients with PCOS, but we see a lot of patients that come in and say something like, oh, my doctor thinks I have PCOS, or they told me I have PCOS, but I looked it up and I don't. So can you describe to us so we can, share with our patient group, how exactly do you diagnose with PCOS? What criteria are there? And when should patients feel confident when their doctor tells them that they do indeed have PCOS?
Yeah, it can be confusing. And the way I explain it to patients is that this is sort of just like a checklist in the clinic. And we have to see if you have yes or no 3 things on this checklist. And one of them is evidence of higher male hormones, androgen hormones. So that could either be by a blood test or either with increased acne or hair growth in a male pattern. And the second one is irregular menstrual cycles. And the third one is polycystic appearing ovaries on ultrasound, so small, little, tiny cysts. And then if you meet 2 out of 3 of them, then those are the criteria that I use, the NIH and Rotterdam. So.
Well, since you trained me, that's the criteria I also use. Yeah. But yeah, I completely agree with you. And a lot of the confusion, I think, comes out of the fact that PCOS is kind of a spectrum. And some women have some of the criteria and some women have all of the criteria. And but so it is sometimes an enigma to diagnose because some women will not ovulate, but will have other 2, and some women will have 2 or 1 or all 3. And so there is a lot of confusion out there. And we definitely recommend that if women think they have PCOS, they reach out to their local fertility clinic or certainly clinics like us earlier rather than later, because acquiring the diagnosis earlier, getting treated earlier, indicates that it will most likely be successful earlier.
Exactly. Like, I hate the thought of people failing to get pregnant for 12 months when it's a very treatable condition. And even more than that, this has long-term health implications, and it seems wrong to tell patients if they already know that they have difficulty with acne and irregular menstrual cycles to not seek help and improve even their health in general, not only just their fertility.
Absolutely. And I think you touched on a very important point, Dr. Wolff, is the recommendations for when women should be evaluated, and men for that matter, and treated for infertility. And there is the 6-month age above 35 or the 12-month age below 35 recommendations. What I'd like to stress, and I think you'll agree with me, is that's for couples or women or men without any pathology. So if women have any stigma of PCOS, certainly if they have irregular periods, there's absolutely no utility. And I think it's counterproductive to let those women and couples continue to wait for those arbitrary timelines in the presence of, said pathology.
Yes, absolutely. Like, because if we treat them a year earlier, their success rates are going to be that much higher, and age is only going to make treatment worse and harder to be successful.
I completely agree. So, Dr. Wolff, I have another question for you, and I think we definitely had a lot of discussions about this topic: is the use of metformin in PCOS. We do see a lot of patients, coming into our practices already on metformin, and I always like to ask the patients, well, why are you taking this medicine? And 9 times out of 10, the response is, I don't know. My doctor put me on for my PCOS. And I said, well, okay, that's great. How do you feel on it? Horrible, right? And then, well, why are you taking it? Well, I don't know. My doctor put me on for PCOS. Well, obviously, like we said earlier, PCOS is a spectrum and has metabolic consequences and reproductive consequences. And, metformin does address both of those to a degree. So do you mind elaborating on what is the appropriate use of metformin in women who have PCOS?
Yeah, I also say to patients that it's confusing because the story has kind of swung back and forth. And at one point, it was one of the preferred treatments for PCOS, and it fits because we know patients with PCOS have insulin resistance, and this drug does help your body process insulin better. And that's one of the ways that we know that we can help polycystic ovary syndrome patients ovulate on their own. So, several years ago, we used to put patients on metformin, but then they did a big trial and they compared metformin alone to Clomid alone or combined, and showed that the highest success rates are with Clomid, and it didn't help to include metformin. So I really like to save metformin for patients who I do a 2-hour glucose tolerance test and they have evidence of insulin resistance. And then I know exactly what I'm treating. The interesting thing that I found recently, and I'm sure you're probably aware, is there are data now that it can decrease the risk of ovarian hyperstimulation syndrome in PCOS patients undergoing IVF. So I think that once you're done trying Clomid at home, some of your IVF doctors might put you on it to try and prevent hyperstimulation as you go through in vitro fertilization.
Absolutely. So newer studies also and newer data indicates that there are some supplements that act a little bit like metformin that potentially can be helpful that people can get over the counter. What do you think about those, and do you use those in your practice?
I see a lot of patients come in on them. I tell patients that that they probably have a low risk of a side effect, but they may not have as high of a chance to help as some other treatments that we have. How about you? Do you put everyone on these?
I tell them there's good data using it from rats, but we're not rats. And obviously we process things a little bit differently. And if you follow the science, that's a popular term these days, on rat studies, it seems that they're not really an appropriate stand-in for human physiology at all. And there's like a lot of, for lack of a better term, fraud when these studies were, and the rats were first being used and how they're processed. So anyway, so I said, yes, there's rat trials data that looks like it's really potentially beneficial. It looks like there's probably not harm from these supplements. So I kind of leave it up to the patient.
Perfect. Same.
Yeah, exactly. Look, but you trained me, so practice in a similar manner.
That
Yeah,
is true.
sure. The other things we always talk about and patients always ask, and there's a lot of discussions online about what is the better drug for women to ovulate. Is it Clomid or is it Letrozole? Obviously, we've used Clomid since the late 60s with pretty good effectiveness. There's always a discrepancy between the amount of women who ovulate versus the amount of women who end up getting pregnant. And then in head-to-head trials, they look similar. So what do you think, Dr. Wolff? What's your preferred ovulation induction method and why?
Yeah, and again, it's sort of these stories that as I get older that I have personal experience telling. But when I was in residency, letrozole was a huge no-no. It was a black box warning that it could cause severe birth defects, and we just didn't use it at all. And Clomid was the only choice. But we did have patients, about a third of patients, where they would have the lining of the uterus get thinner. So sometimes it would be successful and help women finally ovulate, but then maybe the implantation rates weren't as good, and that limited the effectiveness of the drug. So then we started using letrozole more, and there's a nice large clinical trial, as you know, that showed that there's less twins. And so now it's almost first line for me because it doesn't have as much endometrial suppression.
Yeah, I agree. And yeah, I find that, obviously from the trials and from our experience in clinical practice, that a lot of women tend to tolerate it a little better as well in terms of the side effect profile. So I tend to start with letrozole myself as well, and then potentially switch to Clomid if letrozole is ineffective in getting people pregnant. I find that most women are going to ovulate on letrozole, either on letrozole alone or with some sort of an adjunct. But if they don't get pregnant, we typically transition to Clomid or something more invasive. Now, the other question that we always run into is, well, how long do we keep patients on a particular agent if they keep ovulating? And so, we typically say anywhere between 3 and 6 months before it loses its efficacy, even if it can get people to ovulate. What do you think, Dr. Wolff?
Yeah, I think that's a good number, especially to give patients with anovulation. We know that they haven't really gotten their year of trying. So if we can at least get them ovulating, then give them 3 to 6 months, really good shot at getting pregnant on their own is probably even more helpful than patients without PCOS that are unexplained infertility. And those patients sometimes have things that we're not going to be able to correct just with letrozole.
Yeah, I completely agree. It looks like we have a question about baby aspirin. Now, I don't routinely use baby aspirin specifically in women with PCOS, and doesn't look like there's any data that demonstrate that it's effective in improving pregnancy rates or ovulation rates in women with PCOS. Um, what do you think, Dr. Wolff? Do you
I,
routinely use baby aspirin?
no, I don't. Not for PCOS.
Yeah, I agree.
Great.